Thank you everybody for joining me at the GHAPP MASLD and MASH Community Network. And thank you to Madrigal for making this possible. Our goal today is to learn something new about MASLD. My name is Edith Johannes. I'm a nurse practitioner at UCLA Health in Los Angeles, California. I've been working with liver disease patients for about 18 years, and I'm still learning quite a bit. If you haven't registered for the class session today, please use the QR code in front of you to register. And while you do that, I'm going to mention some of the abbreviations that I will be constantly referring to. And these are MASLD, which is the metabolic dysfunction associated steatotic liver disease. ALD is alcoholic liver disease, and MetALD is metabolic associated liver disease, alcohol liver disease, sorry. And like I said, our topic today is not only MASLD, but is looking at MASLD with a little bit of a twist, and that is MetALD. So as you can guess by the title, it is alcoholic liver disease with a twist of metabolic dysfunction. The way we're going to talk about this today is through a case study. So let's meet our protagonist. Her name is Ashley. She's 52 years old. She's a Caucasian female. She does have a little bit of weight on her. Her BMI is 29.4. She's not at greater than 30 where we can say she's obese, but she's getting up there. We also meet her because her primary care nurse practitioner sent her over to us because she found that her LFTs were slightly elevated. And they did an ultrasound that showed that there was some echogenicity in her liver. And that is very consistent with steatosis of the liver. When she comes and sees you, she tells you that she's actually feeling pretty well and she doesn't have any complaints and she's not really sure exactly why she's here. You talk to her about her history and she does tell you that she's got a history of PCOS, which we know has a correlation with insulin resistance. She also has hypertension and hyperlipidemia, which is being treated for with amlodipine and torvastatin. You also notice on her medication list that she's taking milk thistle, and because she heard this is good for her liver. And I'm not going to get on my soapbox, but I usually try to tell people to stay away from any over-the-counter supplements, but I won't go there today. On physical exam, you notice that she doesn't really have any physical signs of liver dysfunction, like no ascites, no icterus, no jaundice, and you do feel her liver, and it's a smooth edge and it is non-tender. Notice that I left the social history for last, and there's a reason for that. When you ask her about her social history, she does tell you that she drinks alcohol, and she drinks about 2 glasses of wine per day. That's what she tells you. So I want to keep that in mind because that is important today. You look a little further and you notice that her blood pressure is elevated, which is not surprising given her history of hypertension. Everything else is pretty unremarkable, and we talked about. The one thing on the labs that I do want to mention is that her platelets are 210,000. And that is reassuring because it tells me that there is no liver synthetic dysfunction, and that is a good thing. The triglycerides are elevated. The hemoglobin A1C is slightly elevated from what's ideal of less than 5.7, but it's not too high. You continue to have more testing because you really want to know where she is in regards to her liver dysfunction. The LFTs are up, so you know something's happening, right? We get a FibroScan, and in the past we learned that FibroScan is very well correlated with the risk of fibrosis. And her FibroScan comes back at 11.4. You can see by the arrow here that it actually ends up being right towards the high fibrosis end. So she is consistent with an F3 fibrosis, which is pretty high up there. But it is important that we figure out whether she's really at stage 3 or 4. And we've done this in our previous education session. One of the ways that we can do that is by looking at the platelets, which we did. So that's reassuring, but also looking at a CAPP score, because the CAPP score shows us the amount of fat in the liver. And we expect that she's got an F3 fibrosis and steatosis and elevated LFTs. We expect her fat deposition in the liver to be high. And it is. The CAPP score comes back at 310. The reason I emphasize that is because if you have a high FibroScan score, but a low CAP score, let's say that would have been down here in the green to yellow, then I would worry because that phenomenon is what we refer to as burnout. And that means that she's got some degree of cirrhosis going on. There's no longer that much fat in the liver. So this is reassuring that she truly is at an F3 fibrosis stage. Now, I mentioned that I left the social history to last because she mentioned she drinks 2 glasses of wine per day. Now, an important question to ask patients is, how much alcohol is that really? And they will usually tell you, well, it's a little, or it's not that much, or it's just a glass, or it's just 1 beer. But I learned very quickly that sometimes that means many things, right? It's never consistent. So we want to ask her, is it really a normal size glass? Does anyone know what a normal size glass is of wine? It's actually 5 ounces. To make it a little bit more interesting, in Europe, a glass of wine is only 4 ounces. Just a little bit of a trivia there. The reason it's important to ask those questions is because we're trying to figure out what steatotic liver disease actually has. We know that it's not cryptogenic and we know that it's not any other disease process because we've already ruled all those things out. She doesn't have hepatitis, she doesn't have Wilson's disease, she doesn't have DILI. But she is drinking and she's got metabolic risk factors. So does she have alcohol-associated liver disease? It's easy to say that she does if we don't want to look further, but she's drinking, but she's not drinking much. And I'm going to change that much to point out here that the amount of grams of alcohol that are consumed are very, very important. So she does not meet that threshold to be considered alcohol-associated liver disease. And I will give you those numbers in a little bit. But the other diagnosis is metabolic dysfunction associated steatotic liver disease, MASLD, or MASH if there's hepatitis going on. However, in order to meet that diagnosis, it is a diagnosis of exclusion. And we're not saying that someone who has MASLD can never drink 1 single gram of alcohol. What we're saying is that they can't be drinking more than the acceptable threshold. That acceptable threshold is less than 20 grams of alcohol for a female and less than 30 grams of alcohol for a male. So where is Ashley at? We'll look at that in a little more detail in a second. So where she is lying is in this area right here, which is right in the middle. She is drinking 2 glasses of wine, which is equal to about 14 grams of alcohol per glass. So she's drinking 28 grams of alcohol daily. So she does not meet criteria to be MASLD alone because it's greater than the 20. So she actually meets criteria to be in this middle ground, which is MetALD, a component of the 2, metabolic risk factors and alcohol use. You can see in this box, though, that it's subdivided even further. There's a continuum of the quantity of alcohol consumed by patients. And it's important to identify where she actually lies in that continuum. Is she drinking a lot that she is kind of towards the right side and ALD predominant? Or is she in the middle? Or is she really on the left side, leaning more towards the MASLD alone continuum? That's important. With her, she's drinking 2 glasses, so 28 grams, and that would put her pretty close to MASLD alone, but not quite. So she's got a predominance of MASLD and alcohol use. That is important because you will see that that really has a lot of bearing in how we're going to treat her. So why is it that we focus on these 2 etiologies? The reason is because you have 2 different entities happening and they both lead to the same problem. If we looked at a biopsy from a patient with just metabolic disease or just alcohol disease, we would not really be able to tell the difference because they both lead to impaired lipid handling in the liver. What happens is that when the liver gets affected and the lipids are not handled well, it begins to produce a lot of oxidation. The oxidative stress that is caused inside the liver cells leads to the production of something called ROS. Now, ROS is actually a good thing because in low amounts, it tells the cells in the liver what to do. It gives them guidance and mechanisms and how to proliferate and what else to do. But if there's too much of it, they just don't know what to do. And then they just start reacting. And when they start reacting, there's a lot of inflammation that happens in the liver. The inflammation happens because there's chemokines that are produced at a high rate. There is impaired immunity, there's macrophage activation. And what that does, it leads to accelerated fibrosis and disease progression. Notice that I didn't say fibrosis and progression alone, I said accelerated. What happens is that it's happening a lot faster than it usually does. Unfortunately for these patients, the fact that they have metabolic disorders and the fact that they're drinking also causes problems in the intestinal system. The intestinal microbiome gets disrupted, and that disruption causes the GI tract to even produce more ethanol on its own, and it produces more liposaccharides, and then there is microbiome byproducts that also lead to inflammation, and now you have even more accelerated fibrosis and disease progression in these patients. This slide here is a little bit heavy to look at, and you're like, where should I start? But let me break it down a little bit. I like it because it gives us a really good idea of the disease progression for these three disease processes in this continuum. If you have MASLD alone, which means down here you're drinking little alcohol, less than 20 grams for a female, the risk of you progressing to cirrhosis, to decompensated liver disease, is about 1% if you have F1 fibrosis. But if you have F3 fibrosis, you would have an increased risk of progressing that is 5 to 15%. Now, if you have alcohol-related liver disease, that risk increases dramatically. If you have F3 fibrosis, your risk of having decompensated liver disease goes up to 15 to 50%. So it is dramatically higher. Decompensation of liver disease either means you will die from liver disease or you will need a liver transplant. That's how serious this is. Now, if your intuition is telling you that patients who have MetALD have a risk that is somewhere in the middle of those two, your intuition is right. You will. Patients with MetALD will have an increased risk from MASLD, but not as high as the ones that have alcohol alone. So their risk is at 5 years with an F3 fibrosis, 10 to 30%. So Ashley is sitting at this 5 risk of 10 to 30%. And the reason that's important is because it's still doubled from what she would be if she only had MASLD. Now, how do we figure out which patients that are diagnosed with MASLD have MetALD? There's been studies that have been done, and they have taken a group of patients with MASLD and have given them questionnaires, and they've done blood testing, different kinds, blood, urine, hair even. And what they basically have found is that about 29% of the patients underreport or do not report at all that they're drinking. And so what this led to is just basically knowing that about 30% of those patients really have MetALD, not MASLD alone. The bottom numbers here just tell us that the best test to do this is the hair test, which looks like glucuronide, which is just the subderivative derivative of alcohol, but it's not a very easy test to do. But we now have more markers, like you guys know, like the PEth test that we'll talk about in a little bit. This next slide talks about how we can diminish that gap of diagnosis of MetALD and find these patients. And one way to do this is to take your patients who have a steatotic liver disease from metabolic factors or from alcohol. And if they have the metabolic factors, but there is no alcohol consumption at all, then you can safely say that this is MASLD. But if there are any kind of signs or hints that somebody could be drinking, then this is when you want to consider doing an audit C and see if they tell you that they're drinking, or perhaps do a PEth test so that you can find out if they are drinking. One of the hints that you could utilize is patients who have isolated hypertension and hypertriglyceridemia, because these two things have been associated with alcohol consumption alone. So it's possible that somebody who's drinking will have high blood pressure occasionally, not all the time, or their triglycerides will go up. And if those are the only metabolic risk factors that are leading you to diagnose them with MASLD, is most likely more of a MetALD process. In the same token, if you have the ability to check for a PEth and you get the PEth results back, this is an easy way to determine where they're sitting in regards to this continuum of diseases. If the PEth is greater than 200, then we know that they are more in the ALD side. But if their PEth is anywhere between 25 to 200, then they are considered to be MetALD. So we get a PEth for Ashley, and what is her result? Her result came back as 120. So that is consistent with moderate to heavy alcohol consumption. And when you tell Ashley this, she's pretty surprised. She really says, I didn't think I was drinking that much. I was only drinking mildly. But the PEth is pretty reliable. And she says, are you sure about that? And we have to tell Ashley, yes, we're pretty sure. They've looked at PEth and compared it to blood alcohol levels. And blood alcohol levels are very quickly peak at 2 hours, and they're detectable up until about 8 hours. After 8 hours, they really are not detectable anymore. But the PEth, on the other hand, is detectable immediately, and it kind of lingers and slowly increases in a day, like 5 to 6. It peaks, but then it lingers positive for up to 12 days. So if you do a PEth test anywhere between days 1 to day 10, you are pretty sure that is pretty accurate. They've also looked at the PEth test and compared it between gender, because we want to make sure that it's not, more positive or less positive in either one. And it was pretty reliable. It doesn't change. They've also looked at it in patients with various BMIs, because we all know that certain substances can linger in the body longer if there is more adipose tissue. But that did not make any difference. BMI variability did not affect the PEth scores. So you can assure Ashley that unfortunately the PEth is correct. They've also done other studies looking at, patients who are overweight, and do they really have metabolic disease? And they started out with a high number of participants, and they did exclude many of them. But in the end, they did analyze 333 patients, and they still found that about 16% of these patients were really more of a MetALD patient than in MASLD alone. This slide just reminds us of Ashley's medical history, and how we mentioned that the hypertension and the hyperlipidemia can sometimes be related to the alcohol consumption. And some of the studies are showing that when somebody drinks alcohol, there is this biphasic effect on the blood pressure. So initially people will drink, and then their blood pressure will decrease. And then about 13 hours after they drank, the blood pressure goes up. So some of these patients are the ones that present to clinic, and you may find them that, 1 time out of 4, they were hypertensive, but not the others. That is the hint that maybe you should check a PEth and see if the alcohol is what's causing their hypertension. Same idea with triglyceridemia. Studies showed that patients who don't have high triglycerides and are given alcohol, the triglyceride levels bump positively. Not totally surprising, right? But what is very interesting is that patients who have high triglycerides already, and then they are given alcohol, the triglycerides increase much more. Okay, so we know that triglyceridemia is definitely a driver for making them worse. overall, this is the case study of Ashley. We have her LFTs that are elevated. We talked about the alcohol consumption, and we talked about how important it is to talk about the amount of alcohol that patients are drinking. I will mention a little bit more about the alcohol amount that patients are drinking because in general, I think we don't ask enough questions in regards to the quantity. I know, for example, for me, I know I had a patient that once told me he was drinking 2 beers per day, and I was like, well, that's not so much. But then when I really asked, he was drinking like a growler, which I then learned that it's like a 32-ounce beer. So that's a big difference, right? And when we put all of this together, we realize that Ashley does have a diagnosis of MetALD. She definitely has the metabolic dysfunction and has a component of alcohol consumption. So she has MetALD, but I think it's also important to note that she has MASLD predominant MetALD. So she's leaning to the left of that curve, or I'm sorry, of that continuum that I was talking about earlier. And I'll tell you why that's important to note. How do we treat Ashley? One of the biggest components in MASLD treatment is weight loss. Weight loss has been shown to decrease fibrosis. It has been shown to decrease the steatosis in the liver, which causes the inflammation. So weight loss is the goal, but how does she get there? In MASLD, we always tell patients lifestyle modifications, and that means changing your diet to less sugar. The Mediterranean diet has been shown to be effective in exercise, and exercise goals are 30 minutes a day for 5 days a week. But the ultimate goal is this weight loss. If she had MASLD alone, we would be sure to implement resmetirom because that is the only FDA-approved drug that is indicated for MASH. However, does she meet criteria to be treated for resmetirom? Unfortunately, she doesn't. She doesn't because even though she's predominantly a MASLD patient, the amount of alcohol that she's drinking is beyond the acceptable threshold. The acceptable threshold is less than 20 grams per day, and she is having 2 drinks. Each one is 14 grams, so that would be a total of 28 grams a day. So unfortunately, she does not meet criteria to be treated with resmetirom. So what is the most important thing to tell her? The most important thing to tell her is to stop drinking. This will make a significant improvement in her overall picture, mainly because if she stops drinking and we can prove that she has ceased alcohol consumption and stays there, we can then in the future have a conversation about starting resmetirom. We can also then see if she adopts any of his lifestyle modifications, what other metabolic risk factors remain. So stopping alcohol use, I think it's the most important in her case. The other thing is that she doesn't have cirrhosis. So do we need to screen for hepatocellular carcinoma? The guidelines, if you really look at the guidelines, they don't say that you have to. However, we did learn that MetALD gives you an increased risk of disease progression. So in her case, I would say, yes, we definitely should screen for HCC with an ultrasound and alpha-fetoprotein every 6 months or so. There is still a lot of work being done in regards to MetALD and the ideal definition for studies for clinical trials because it's still not perfect, right? And if we have an ideal definition for it, I think it'll help overcome some of the underreporting. It would help if we had like a standardized way of confirming the use or not use of alcohol. And we also need to remember that if people do adopt some lifestyle modifications, we need to reassess them for this cardiometabolic risk factors because patients who adopt lifestyle modifications may no longer have hypertension and hyperlipidemia in time. So we need to remember to reassess. And this reassessment is not just in clinical practice, but it is in these clinical trials that are that are taking place. It's also important to know that a lot of the patients that start trials, they no longer meet the criteria for them to continue on this trial. So the questions that arise is like, who are the patients that are staying there, right? So the data will only be as good as our process. The take-home messages for today are that MetALD is a new definition. And I think the whole point of today is to really broaden your perspective on the patients who are diagnosed with MASLD, and even the ones that are diagnosed with ALD. Are they really just an ALD patient, or do they have a lot of those comorbidities or, metabolic risk factors? This is just to make you do a little mental gymnastics here, but the definition of MetALD is patients who ingest more than 140 to 350 grams of alcohol for women and more than 210 to 420 grams of alcohol for men. That is the weekly numbers, but if you divide that by 7, you go back to the 20, 30, 50, 60 for women and men respectively. There's also a good idea to use the PEth clinically because it will help us to place these patients in the right category. And it's also important to reassess for the cessation of this metabolic risk factors if the patient does change their lifestyle. And the other ones really just talk a little bit more on what other research is necessary. And some of it is that we have to remember that MetALD and MASLD are affected by a lot of social cultural realities, like Hispanics tend to have a faster progression of MASLD to cirrhosis and liver failure. Thank you very much for spending the time with me and learning about MetALD. If you want to learn more about MASLD, MASH, MetALD, please use the QR code. And if you want to learn more about resmetirom, use the QR code. And if you have time and are willing to give me some feedback, I would appreciate it. Thank you very much.